Oh, no. Closer. Yep.
How do you process white bread with peanut butter?
Actually, I found out that Kergin under Kergin cardiac and vascular. Yeah. I'll check it sometime. Yeah, we're good. Okay.
I'll just make sure this is good morning, everyone, and welcome. This is our university rounds, which we have monthly on the first Friday of the month. And this is the Kergin lecture. And I'm really delighted that Dr. Rebecca Auer accepted my invitation to visit us. She's going to be staying on for some discussions and research presentations after throughout the day. And I think she'll have a little bit of extra time if anybody wants to meet with her. I'll begin by just acknowledging on everyone's behalf that the land on which the University of Toronto sits and on which we work is the traditional homeland to many Indigenous peoples, including the Anishinaabe, the Haudenosaunee, the Huron-Wendat, and the Mississaugas of the Credit. We are privileged to work and think and live on this land and to share, and we pledge to be better stewards in harmony with our Indigenous colleagues and friends. Now, the Kergin lecture originated in recognition of Fred Kergin's contributions to the Department of Surgery, not only as chair, but also in many other roles at the University of Toronto over the course of his career. He's a Rhodes Scholar, and he also became an Associate Dean of Clinical Affairs at the Faculty of Medicine. Under his leadership, there was an integration of residency programs in the Department of Surgery and also differentiation into specialties with the development of the Division of Plastic Surgery and the Division of Cardiovascular Surgery. And he is a very well-known, innovative thoracic surgeon. As you can see there, the Kergin thoracoplasty and bronchoplasty procedures were developed by him. And the previous Kergin lectures, you'll recognize some of these names. It's quite an eclectic group of people. going back to Bernie Langer, Bob Stone, Alec Patterson, and then more recently, people like Danielle Martin and Hussein Malou, who visited us last year. And I'm really pleased that Dr. Auer is joining this list of august visitors. Rebecca's really had remarkable achievements in her career. She's currently the scientific director for the Cancer Therapeutics program at the Ottawa Hospital Research Institute. As many of you know, she's a surgical oncologist who specializes in colorectal cancer surgery and retroperitoneal sarcoma at the Ottawa Hospital. She's also a professor in the Department of Surgery and the Department of Biochemistry, Microbiology, and Immunology. And she's had a career-long interest in immunosuppression perioperatively, what drives that and how it can be reversed. She's a brilliant clinical trialist, not by training, but by experience. And I think she's going to give us a perspective on her career experiences and also more recent personal experiences. So please help me in joining Dr. Auer, in welcoming Dr. Auer to join us today. Slides. Why is it not doing so? It should be. Yeah. We're having a bit of technical difficulties right now, so if you bear with me for 1 second. Oh, 1 second. There we go. Sorry about that. Okay, we're almost there. Okay, we've got it.
So thank you so much, Dr. Swallow, and everyone in attendance today for this honor and this invitation. When Dr. Swallow asked me to speak, she initially said if I could talk about the role of hope in patient care and in research. And to be clear, I'm not a hope expert, that's for sure. And there certainly are those people who study hope and its role. But I am a hope believer. And I do think that we need to be very conscious of the role that hope plays in the journey that our patients are on. And so I'm excited today to tell you a little bit about the journey that brought me to that revelation and what I think we could all possibly do about that. Okay. So I'm a translational researcher, and I have a lab where we do animal studies and petri dish type studies, and then I also have a clinical trial program. And so I think a lot about translational research, and I think the paradigm of translational research is kind of, we have biomedical discoveries, they're in the lab, and we bring them to the first inpatient kind of clinical trials. And for some of those discoveries and for some of those patients, they experience a really dramatic response and sometimes a cure in an unexpected situation. And I call that part of that paradigm making the miracle. Because for those patients at the end of a survival study who are censored at the end of that study, meaning that they haven't experienced the outcome of interest, like disease recurrence or death, they don't feel like they've been censored. They feel like they've experienced a miracle. They were told that they were incurable maybe, and they feel that they may be cured. And so I call that making the miracle. And then we have this process where we have to rigorously evaluate those miracles. Why did those miracles happen? Do we understand the biology behind it? Who is going to get the miracle? So patient selection. When do we use the molecule or the drug to figure out how to increase the number of miracles? And I call that unraveling the miracle or demystifying the miracle. And then lastly, we need to understand how can we use this in our clinical practice, and how can we make this no longer a miracle, but just what you do when you have this disease. So you have cancer, you have this type of cancer, and this is the type of treatment you have, and there's a very high chance you'll be cured. And I call that normalizing the miracle. And so for this survival curve that many of us are familiar with, I call this end of the survival curve, the tail of the curve. And that's what patients want. And I'm going to talk mostly about cancer because I'm a cancer surgeon and a cancer researcher, but I do think that this applies to many outcomes and many different diseases that we look after. What patients want is to be on the tail, to have not experienced the outcome, or to have had the success at the end of the study. And I think this paradigm is really important. And I don't want to pretend that this is not how we should be understanding things, but I think the process and the way that we've been doing this for years, decades, many decades, I think we need to reimagine it and rethink it. And the reason I think this is partly because of these three patients and the story that they bring to my career and my perspective. And so I'm going to tell you these three stories and how they've changed the way I think about research and this process. I'm going to talk about Adam, Camille, and Hayden. And all three of these patients are giving me permission to talk about their story, of course. So first I want to talk about hope. I think that there are many, many studies out there, and I won't go into all of them, where hope is associated with improved resilience, improved quality of life, reduced anxiety, depression, and longevity in almost every disease studied. And in cancer patients, actually, the importance of hope is reported by cancer patients as being extremely important. And that doesn't matter whether you are in palliative care and you have been told you have a few days or weeks to live, or if you have very early stage, let's say breast cancer with a 90% chance of being cured. Hope is actually more important in the palliative setting than even in the very early settings. And I would like to argue that there's no such thing as false hope. There's false information, but there's not false hope. Patients may want to hold on to the 1%. And that's why I've come to the conclusion that it's the journey that's just as important as the outcome. Because living with hope is a lot different than living without hope. And so sometimes the outcome isn't as important as the life that you lead before you get to that outcome. Ultimately, we all have the same outcome. We will all end up not being censored at the end of the day. So when it comes to cancer and survival, thank you. We will all die. And so the journey is probably just as important as the outcome. Christopher Reeve famously said, "One should choose hope, anything is possible." And I like this quote. I think it's an important one because he was, as you know, paralyzed from the neck down, tragically, but he refused to live his life that way. He always believed that there was a chance that he would be able to walk again. And in fact, towards the end of his life, he was able to move one of his arms completely. And he has pretty remarkable recovery compared to most patients in that situation. But probably more importantly, he lived every day with hope and with joy and with courage. And I think the journey is just as important as the outcome. When my middle son was about 7, he came home from school one day. We were having dinner, and I have 3 boys. And he said, what is the most powerful word in the English language? Obviously, we learned this at school. And so we all had our, words that we chose. My youngest was about 4 at the time, and I think he said like pumpkin pie because it was Thanksgiving. And my eldest, who was about 7, said love, which I thought was a pretty good word. But Matthew said it's yet, because if you put yet at the end of any sentence, you make something that's impossible possible. And so they had to write these sentences. His was some soccer kick where you kick it over your head and get a goal while doing a backflip. I can't remember what it's called now, but he said, I can't do that yet. That was what he wanted to do eventually. So I think, to me, research is the driver of hope, and it gives you the power of yet for patients. And I believe that when we talk to patients, we should remember that we don't know what the future will hold necessarily. So I'm a big fan of Simon Sinek. I know he's somewhat overused, but he writes the book Start With Why, and that for me is the why. Research gives us the power of yet. So I think it's important to remember where we have been in terms of cancer therapy. When cancer treatments were first kind of starting to come into the medical field, in around the 1930s and the 1940s, there was really a philosophy of we need to kill the cancer, but we need to not kill the patient at the same time. And so the early therapies were certainly very toxic. And don't get me wrong, they certainly have had their success in many realms and continue to be the backbone of what we do in cancer medicine. But, at the time of surgery, for example, in the Halstedian days, it was, cut the breast off, and if it comes back, you probably needed to cut more. And if it still comes back after that, you probably needed to cut more. And so there was really this sense of the more we cut out, the higher your chance. And of course, unfortunately, that doesn't work. We had the field of radiation therapy, which again was highly effective in some cancers, but certainly associated with toxicity. Chemotherapy, of course, was a huge backbone and continues to be a huge backbone. And this picture of Cornelius Rhodes, who's on the cover of Time magazine. He was actually the first director of the Memorial Sloan Kettering Cancer Center when the Cancer Center and Memorial Hospital came together. And took over from James Ewing in around 1940. And he actually was during the Second World War, worked for the US military as the head of the Chemical Warfare Division. So that's his background, is toxic poisons to kill enemies. And that's exactly what they sought out to do, kill the cancer enemy with toxic poisons. So again, not to discount how much chemotherapy has really transformed the field of cancer therapy, but indeed that was the background of these cancer treatments that really that we use today. And we know that they come with a lot of side effects for patients, of course, disfiguring long-term and pretty debilitating during treatments themselves. So that's where we've been, and this is where we've been in terms of clinical trials. We have a sort of concept or algorithm where we have a group of many patients, and we have a new therapy, and we need to test it first for safety in a small number of people, make sure it can be tolerated, find out what the dose we need to give is, then treat more patients to see if we have any responses, and again, making sure that we're using the right dose that's not going to kill the patient, but it's going to have some improvements. And then finally, many patients in very large, what we call phase 3 trials, where we're now I'm going to understand if there is efficacy in a larger cohort. And this algorithm, clinical trial algorithm, really has been in place for many decades. And there's been a very strong and deep division between what we consider to be clinical research and what we consider to be clinical care. Well, clinical care and clinical research are very different. They're treated differently in the hospital, they're funded differently, and we have to think about them differently. And that's where we've been. And there's a very good reason why this has come about and why research and care had to be so clearly separated in the past. Notwithstanding the fact that research involved very toxic chemicals by and large, at least for cancer. So we need to be very clear about who was getting them and why they were getting them and what was the benefit and what was the risk. I know many of you would be familiar with the Tuskegee study, but I think it's probably worth remembering that study because it really has led to what we now consider probably the central documents around the delivery of clinical research. So that was a study that was undertaken by the U.S. Public Health Service between 1932 and 1972, and about 600 African-American men were enrolled, and they were tested for syphilis, and just over half of them tested positive for syphilis. The participants were not told of the diagnosis, and they were somewhat misled as to why they were doing this study. They were told that they would get free healthcare. But in fact, even when penicillin was determined to be a very effective treatment in 1947, participants were not treated. And in fact, when the draft came and participants had to go and be tested for syphilis before they joined in the Army, the researchers actually convinced the military that these particular patients could not be treated for their syphilis and were told. So really egregious human rights violations there. The study was stopped in 1972 because it was leaked to the press. And by then, 128 participants had died directly or indirectly from syphilis and its complications. 40 lives have been affected, and 19 children were born with congenital syphilis. And so this really was one of the major impetus to create the Belmont Report, which since then has now been revised and continues to be, though, the really central document that informs how we do clinical research. And it's based strongly on respect for persons, beneficence, and justice, and these ethical principles. And I want to be clear, I think it's absolutely critical that we continue to uphold those principles. Those principles are absolutely critical. But I do think we may want to rethink how we do that in our current paradigm. Of course, the common rule is an American concept, but it's true in Canada as well. And essentially, it's a set of 5 rules in research ethics, and they're the things that we're all familiar with. We want to minimize the risk. The risks have to be reasonable. Patients have to be recruited equitably. We have to have a documented informed consent with monitoring for safety, protect vulnerable patients, and maintain confidentiality. All of these are important. What I would argue, however, is where we are now in our biomedical research journey, we need to rethink how we do this. So where are we now with cancer therapy? Things are very different than they were when cancer therapies first evolved. We have had this incredible explosion in research and our understanding of cell biology and molecular biology. I mean, we have had multiple decades of really looking under the hood of the cell and understanding exactly how that cell is functioning. And this has led to a real expansion in the fields of molecular therapy, for one. So consider this, that we sequenced the first human genome, and that was completed in 2003. It was 20 years ago, but it cost $2.7 billion and took 13 years. 20 years later, we can sequence a full human genome for a little over $1,000 and it can take 1 to 2 days. So this is an incredible transformation in our ability to understand the cell. Same with CRISPR-Cas9 gene editing, which I'm sure you're all familiar with, also resulted in the Nobel Prize. But it was actually just discovered in 2012 in the Streptococcus pyogenes bacteria. Essentially, for those of you who don't know, CRISPR-Cas9 is how strep pyogenes can delete bacteriophage DNA from its genome, which has gotten incorporated. And the Cas9 allows guide RNAs to find the gene of interest and delete it, and can even reinsert a different gene. So this is an incredibly important genetic engineering tool that exists in nature. And now, just over a decade later, the first FDA-approved therapy using CRISPR-Cas9 gene editing was approved in December 2023. Many of you probably heard it on the news. It's for sickle cell anemia. Essentially, what they can do is they can take cells out of the patient. They gene engineer them so that the regular sickling hemoglobin, the promoter is removed with CRISPR-Cas9, so they can't make the regular hemoglobin, which forces the erythropoietic progenitor cells to make fetal hemoglobin, which actually doesn't have a sickling problem, and essentially cures them. Costs about $2 million at this point per dose, but it's a cure. It's a pretty incredible transformation. We've also had this explosion in immunotherapy, and a concept that's always been there, that our immune system can kill cancer, but only really in the last decade have we been able to show that that's actually fundamentally possible. Immune checkpoint blockades are really the first that came on the scene. Anti-CTLA-4 and anti-PD-L1, PD-1s, for those who don't know, they turn off the brakes on our immune system, essentially. Thought to be mostly T-cell mediated, although I think it's NK cell mediated as well, but that's for a different talk. And then we have cellular immunotherapies, and these have also really transformed treatments. And again, with CRISPR-Cas9, the possibilities are almost endless. So the first FDA-approved cellular immunotherapy was in 2010. Today, there are 26 cell therapies, and 7 of those were approved in 2023. And there are over 5,000 clinical trials of new cell therapies in the pipeline, and I think about 150 or close to 200 brand new therapies that are being tested. And then the first tissue agnostic approval. So it doesn't matter where your cancer came from, doesn't matter what the primary site was. You can get a therapy if you have a particular molecular mutation, and that was with immunotherapy. And that happened just in 2017. It was a completely landmark decision by the FDA. So really things are very different than they were from a biomedical point of view. Oh, this was I was supposed to let it play. This is my T-cell killing a tumor cell video, which I just think is really cool. It's in real time. So where are we going? Well, now we have an ability to molecularly characterize different cancers. What mutations do they have? What specific molecular therapies will they respond to? And we have probably 50 or 60 today. But the future is hundreds and thousands of these. And these hundreds and thousands of these are possible. There are thousands in the pipeline now, and that's only going to increase. And you can see from this chart of FDA approvals by year for oncology drugs, there's a huge expansion by every year over year of the number of drugs that are approved. And so this is going to get increasingly complicated, and there's going to be increasing options for patients. And so how are we going to figure out what to give patients? And how are we going to figure out what works and when does it work? I'm pretty sure we're not going to figure it out this way. And that's what I'm trying to, I guess, explain. We have this algorithm that makes it seem like every patient is the same. And then we try a treatment on those patients, and some patients benefit and some don't. And then we decide if it's effective based on what the proportion is. But what we might simply be measuring is the proportion that has a very specific mutation in that population. And so trying to fit in this highly complex molecular understanding of cancer biology and cancer patients into this design is, I would argue, probably not going to work. And I think we're seeing it. So again, I think we need to reimagine how we are asking and answering these questions while still upholding critical principles of beneficence, justice, and patient autonomy. So this is Adam's story. Adam is the father of 3 boys, and he was recently appointed as CEO in the Cement Association. And in May of 2022, at the age of 49, he was diagnosed with stage 4 cholangiocarcinoma. Cholangiocarcinoma, for those who don't know, is cancer of the biliary tract. And it is fairly rare, less than 1,000 patients in Canada diagnosed per year. And at stage 4, the life expectancy is about 7 to 11 months. The probability of living 5 years is less than 2%. So Adam was started on standard of care chemotherapy. So this is a picture of Adam. He's an avid cyclist, father of 3. This is devastating for a 49-year-old father. And I know that for sure because Adam is my husband. And I can tell you that in May of 2022, I really had no hope. I really thought that this was what our life was going to look like. I've helped a lot of people die. I've seen a lot of people die of cholangiocarcinoma. I've seen them emerge. They're yellow, they're swollen, confused, they're in pain. I was terrified of the future. What surprised me was my husband, who was so unbelievably courageous in this devastating moment. And I remember very early on, we were sitting together and I was very sad. And I said, you know, honey, this isn't the story I wrote. This isn't the book I wrote for our life. And he said, sweetie, you don't write the book. You don't write the play. You just play the part. And I don't know about you, but I'm going to play the part as best as I can because I'm going for an Academy Award in my own life. And that really made me realize that he has a lot of strength and courage in this facing this diagnosis, and I need to meet him now. So I think in those early days, I was really scared, and I had kind of accepted the fate that my husband was going to die of this cancer. And I remember going to the lab to pack up some things, and I met my mentor and good friend, John Bell. And for those who don't know, John Bell is pretty unbelievable scientist. So started Canada's Immunotherapy Network, which is a large M.Sc now funded through the Strategic Science Fund. Lost his own daughter to leukemia many years ago. And he was kind of looked at me and he was like, why are you so upset? And I was like, John, Adam has like a year to live. He said, no, but like, didn't you go down to the NIH and wasn't there that woman down there that they cured with T-cell therapy? And I remembered that, yeah, I had gone down and on a research visit, and I had heard about this woman who'd been cured on T-cell therapy, and it was quite remarkable. And I said, you know, John, that's one person in the world cured of cholangiocarcinoma. And he said, well, maybe now it'll be 2. So I think you're overthinking this. You know, you don't have to cure everyone. You just have to cure your husband. It's only one person. And then maybe, you know, cure a few more while you're at it. Like, we can figure it out. And it sounded ridiculous at the time, but I have to say that moment in that journey was really transformational for me because I left the office and I started to have hope. I mean, hope that seemed to come from nowhere. I mean, what does John know? He's not even a clinician, but he gave me that possibility that maybe the outcome would be different. And I don't think it matters whether the outcome was going to be different or not. What matters is how I lived in that moment and those days to follow. So Adam started on standard of care treatment, chemotherapy, gemcitabine and cisplatin. He worked through the whole thing. He hates that picture, it's online, but he gave a speech with no hair, no eyebrows. said, lots of guys don't have hair, but he's like, nobody doesn't have eyebrows. And his care was different though. So for example, I knew right away to get molecular testing, not funded by the government, not really available for cholangiocarcinoma at all. But we paid out of pocket and we sent core biopsies down to the US and we got some molecular testing. We also got compassionate access to immunotherapy. Immunotherapy, this TOPAZ trial had not even been published, but it had been presented at a meeting. And so we knew that there was some indication that some patients who got immunotherapy seemed to do better. And I was talking about the tail of the curve, and here's the tail. These are the patients that got their chemotherapy with immunotherapy. And there's definitely a few patients that seem to be hanging on here, an excellent response. So that gave me some hope as well. But it's still not funded in any province in Canada. Turns out that Adam had a BRCA2 mutation. And that mutation is very rare in cholangiocarcinoma, about 48%. But what's interesting is we now know, some more than a year later, that this tail is enriched in BRCA mutated patients. We didn't know that at the time. So if you are a BRCA mutated patient on this trial, your chance of being in this tail is over 60, close to 70%. You have about a 70% chance of being one of these people on this censored at the end of this study. And also, there's a targeted agent for BRCA mutated cancers. Obviously, never been tested in a phase 3 trial in cholangiocarcinoma. It would be nearly impossible to do that. But it has been tested in phase 3 trials in many other more common cancers: prostate, pancreas, ovary, breast, and it was a positive study in all of those cancers. In fact, there's no cancer for which PrEP inhibitors, the olaparib, has not been a positive study when they're specifically looking at the BRCA mutated. So after he finished his chemotherapy, he stayed on immunotherapy. We started the PARP inhibitor, which we had the luxury of paying for out of pocket. And we went down to the NIH, where Melinda Bikuni, the woman I had heard about so many years before, had been treated and cured. And he was enrolled on a clinical trial of a personalized T-cell therapy. Today, Adam is doing well. He's working full-time as CEO and father of our 3 children. And we now talk about our future in a way we never did before. We talk about our grandkids. We talk about what we'll do when we retire. That may not be our future, but I live today with the hope that it might. But again, Adam's care was different. We had access to immunotherapy through a compassionate access program, which some patients have access to, but many do. It's not funded in Canada. Not even for BRCA mutated patients, which we wouldn't know because we don't test them. Because molecular testing is not available. You have to pay for that out of pocket too. The drug that we got, the PARP inhibitor, also not paid for by the government. And it costs about $9,000 a month for that drug alone. So pretty unaffordable to even the average Canadian. And we even out of country to access a clinical trial. T-cell therapy like that is not available in Canada. So these are pretty major barriers, I think, in accessing the type of experimental treatments that may have made the difference for Adam. This is a report that came out by a group called Access to Genomic Testing. It was sort of a report card province by province of readiness to deliver on molecular testing. And Ontario got a D, which is not a very good grade. And I think some of the problems are that we only cover molecular testing after the fact, after there's a drug that has clearly been shown to work in a very specific scenario. That's when we start to cover molecular testing. And usually the time it takes to get that testing implemented is actually well beyond when the drug actually is available. The access is different by different provinces, and even within one province, even in Ontario, depending on what hospital you visit, you have different access to different testing. And there's not always standards for how that testing is. So for example, in cholangiocarcinoma, there's a gene translocation fusion called FGF2, for which there is a drug. Some labs don't use a test that can detect that. Some labs use a molecular test that misses 90% of those translocations and fusions. So they're telling the patient they don't have translocation and fusion, and there's a 90% chance that they are wrong. And there's no standards for that. And it's not available to help patients find a clinical trial, which means that it's very hard to get clinical trials in Canada for these molecularly targeted agents because it's almost impossible to find these patients. And so then when you look at our traditional clinical trial algorithm and you take a trial that needs 1,000 patients, well, that's not going to take years. That's going to take decades if you have a rare cancer. And it no longer starts to make sense. And this is the Canadian reality. We can't even do this because we don't even know which patients are green and pink and purple and blue because we're not even testing for it. And so patients are left with paying for their own testing or having a clinical trial that pays for that testing. And when you're looking at mutations that are in the frequency of about 1 to 4% in the population, that's a lot of people to test for a clinical trial to find a few that might be eligible. But if they do get testing, then they can either try and find for rare cancers a site-specific clinical trial. It can be very challenging. Sometimes there's a site-agnostic clinical trial. So if you have this mutation, it doesn't matter where the tumor is, you can join the trial. Sometimes you can get compassionate access, or you can pay for off-label use. But most of the time, you get no access. And this, I would argue, is creating these huge disparities, the ones that we were trying to prevent. There's no equitable access to clinical trials in Canada for this. You have to have enough money to know what targets you have. You have to have enough money to travel to the site where the trial might be open. And if you're lucky, there's a trial site open in Canada, probably in Toronto. So I'll tell you next Camille's story. Camille's a single mom. She recently accepted an offer to start her dream job in New Market, Ontario. And she was diagnosed with acute lymphoblastic leukemia in January 2020. She was 35 at that time. She was treated with the standard of care chemotherapy and stem cell transplantation at Princess Margaret. Unfortunately, the cancer recurred in March 2021. At that time, there really was no curative treatments available for her in Canada. But there was a treatment that was completely transforming care called CAR T-cell therapy, so one of the new cell therapies. Essentially what CAR T-cell therapy is you take T cells from the patient, you engineer them either with a retrovirus or a lentivirus to express a T-cell receptor that targets CD19, which is present on all B cells, but is always present on the leukemia. And then you deplete their immune system completely so you can reinfuse the CAR T cells and they attack the cancer. And the first time this therapy was used for acute lymphoblastic leukemia in a pediatric patient was in 2012. And the therapy was developed by this researcher, Dr. Carl June. And I had the great pleasure of meeting Carl and having dinner with him one night. And he told us the story of Emily Whitehead, who's quite famous now because she is now, of course, alive and cured 10 years later. It's only more than 10 years now, of course. But she was 6 when she had this recurrent lymphoblastic leukemia diagnosed. She'd been fighting leukemia for several years at that point. And this was kind of their last hope, CAR T-cell therapy. And they knew they were the first patients to receive it. She received the CAR T-cell therapy, and fairly soon after that, she went into a coma. Was very, very sick, very high fever. And she was intubated in the ICU. At the time, Dr. June, who was not the PI on that trial, was actually on a flight to Hong Kong. And the parents were trying to decide, should we withdraw care? Our daughter's been through so much. It's just been awful. And maybe it's time to let her go. You know, she's suffering and we've really put her through too much. But they decided to do a blood sample and send it for a cytokine panel. And they noticed that her levels of interleukin-6 were incredibly high, like off the charts, couldn't be read on the test. So the PI of the trial said, well, can you get Carl June on the phone? I just want to ask him what he thinks about this. So Carl's on the plane going to Hong Kong. Making an announcement, is Dr. Carl June on the plane? The pilot has a phone call. You need to come to the cockpit and take this phone call. So he picks up the phone As you know, and he tells the story, and he's so emotional. He's almost in tears when he tells the story. So they said she's got these really high levels of IL-6 and they want to withdraw. If they'd withdrawn care, that might have been the end of CAR-T. Might have ended that trip. The first patient dies. Maybe never given to another patient. It turns out, although he was older, he'd married again. He had a younger daughter, who's just a few years older than Emily, who had rheumatoid arthritis, and she was taking a drug called tocilizumab, which blocked IL-6. And so he just happened to know that there was this drug. And he said, give her tocilizumab, try it, it's worth it. So they had to quickly call the FDA. They had to get immediate approval to give tocilizumab. They had to find a dose of this drug somewhere. They gave it to her, and 24 hours later, she woke up. And now she's pretty incredible stuff. Anyway, CAR-T therapy has transformed care, but not really in Canada, at least not at that time. So the first trial, as I mentioned, was in 2012. And then subsequently, there was two phase 2 trials that demonstrated more than 50% survival. In one trial, 70% survival in these patients. And their survival was long-term. And this is a disease that is universally fatal in 3 to 6 months, universal at the time of recurrence. So CAR T-cell therapy was actually approved in 2018 based on this data, as it was approved by the FDA and Health Canada. But at the time, even though over 64 CAR T trials had happened worldwide, there had only been 2 trials in Canada, only until about 1 site, Princess Margaret. And so that meant that there was very few patients during that clinical trial period in Canada that possibly have been offered that treatment or benefited from it during that time of testing. But it also meant that none of the medical oncologists and hemo-oncologists and providers had any experience with CAR T-cell therapy. It also meant that we had absolutely no infrastructure to make CAR T-cells and deliver them. The cost of CAR T to send patients to the US is about $1 million. And we have a lot of actually incredible researchers and scientists who have next generation CAR T cells, but there's nowhere in Canada for them to develop these CAR T cells. They're forced to sell them outside to the US. So this group of people back in 2016 were talking about this, but the fact that we had no trials in Canada, the fact that it was going to be very expensive when it was approved, but the writing was on the wall. This was very likely going to work. It's working so well in trials. And Natasha Kekries, up here in the corner, she had just come back from the Dana-Farber, and she's an amazing, very tenacious young woman. And she said, why can't we just make CAR T cells in Canada? And basically they were together at the bar, this group of people, and they said, yeah, let's make CAR T cells in Canada. And so they did through BioCanRx, and John Bell is one of the founders of this group. They decided to figure out how to develop the infrastructure and expertise to manufacture and deliver CAR T cells in Canada. And their main reason was so that they could provide an alternative to Big Pharma for developing novel CAR T cells for our academic scientists and also Canadian biotech, to have clinicians across Canada have some experience with the delivery and the side effects of not just the current CAR T cell product, but the future CAR T cell products that are most definitely coming down the pipeline. Also to create an affordable option for CAR T. So actually we can manufacture CAR T cells for about $60,000 to $70,000 US a dose. And then the cost of delivering those cells, which is about like a stem cell transplant. So really like a fraction, probably about 1/10 of what it costs for Big Pharma, or what Big Pharma charges us, I should say. And then we would have access for Canadian patients for not just this CAR T, but also for future CAR Ts. So Camille did get on the CAR T therapy through BioCanRx. She wasn't eligible for the commercial product. It was only allowed for patients 25 and under at that time. But she was able to get on the CAR T trial, mostly because of her incredible personal tenacity and courage. So she came down to Ottawa. She heard about this program, and she came down to Ottawa. The first time she came down, she was coughing. She did chest x-ray, she had some nodules in the lung. It turned out she had a fungal infection. She had to go back to Princess Margaret, treated for antifungals, finally got better, came back down to get enrolled. The night before coming to the hospital, she had a seizure, ended up in Merge, CT scan, brain mets, back to Princess Margaret, radiation, targeted radiation to the brain mets, got better, came back to Ottawa, got on the CAR T cell therapy trial, and is now disease-free and cured. She's doing well, raising her daughter, almost back at work. She has a lot of side effects from the original treatments, not from the CAR T, but from all the first treatments that she had to go through. Because of course, CAR T is a last stage, not a first stage. Even though arguably that's what we need to do. But she's an incredible advocate for cell therapy and for academically driven cell therapy in Canada. Last story is Hayden. Hayden's a patient of mine. He's a semi-professional soccer player. He did his master's at the University of Florida while playing soccer, and he was actually training with Real Madrid. It was COVID, so he wasn't home with his family. He hadn't gone home to visit, was having rectal bleeding. His coach told him it was hemorrhoids. He did go home finally to visit his mom, and she said, "You're going to the doctor." He had a locally advanced rectal cancer. He was diagnosed in the spring of 2021. At that time, he was 22 years old. So he was scheduled to start total neoadjuvant radiation and chemotherapy, followed by surgical resection. When I saw him, he was supposed to start the following day. And he was likely to be cured, but it was months of treatment, probably would have a permanent colostomy, probably be impotent, probably have neuropathy in his hands and his feet, never play soccer again. But he was so young, no real family history. We thought he must have Lynch syndrome, or he must have a mutation. You know, let's see if we can get molecular testing for him. It wasn't standard even at that time, although certainly some hospitals, I'm sure many hospitals here were already doing it. So we called the lab, I called the radiation and medical oncologist. We put things on hold and we got his testing for MSI, which most of you will know, it means he has a defect in DNA mismatch repair proteins. And so that's the driver of his cancer. And indeed, he was MSI high. And so we know that MSI high cancers are particularly susceptible to immunotherapy because immunotherapy works when the cancer cells have a lot of mutational burden, because the immune system can recognize that as foreign. And of course, if you have a defect in your ability to repair DNA, you're going to have a lot of mutations. And this is just a circus plot here of a microsatellite stable, so a regular rectal cancer, or not even rectal, this is any cancer. And then the MSI high form that has the defect in DNA mismatch repair. And each one of these red dots is a mutation, a non-synonymous mutation that changes the protein. And so you can see how many more mutations. So it's something like 10-fold to up to 20-fold increase in the number of mutations per 1 million base pairs. And this graph shows you that the more mutations within a cancer, the more likely they're responding to immunotherapy. So we knew this, we've known this for a while. And in fact, as I mentioned, anti-PD-1 therapy was actually the first time the FDA ever approved a tissue agnostic or a tumor site agnostic therapy. And it was based actually on 5 phase 1 and 2 single arm studies, not a phase 3 study, which I think is quite promising. What you can see here is the blue patients or participants are the ones that have MSI high cancers, and this is their response here. And obviously the red ones did not have MSI high cancer. So it's pretty obvious it's very targeted to those patients. This is not Hayden, this is a different patient, but this is a rectal tumor before treatment. And this is the rectal tumor 6 weeks after treatment, 2 doses of immunotherapy. Pretty unbelievable responses, really a miracle in those patients. And I have to say, I could not bear the thought of Hayden going through chemotherapy and radiation and all of the aftermath. 22 years old, sons of my own, and so I asked our team, isn't there any way we could find a way to give him immunotherapy? And we were very clear with Hayden and his family. This is experimental. It hasn't been used in this early stage. We do not know that this will work. But we had, friends at Memorial Sloan Kettering who were giving immunotherapy to rectal cancer on a clinical trial that he would not have been able to afford to travel down to the US to participate in. And we knew the results were incredible. So far, 100% of patients have had a complete response. So we wanted to offer this to them. And through a series of CT scans and slightly enlarged epigastric node, we were able to treat him with immunotherapy. And this is a picture of him on immunotherapy that summer. I asked him to send me a picture to convince people how well he was during immunotherapy. And of course, says at 22, yeah, this is what he sent me. So, so we had that treatment started in May and we had surgery in September. Probably didn't need surgery in hindsight. He had a complete response, recovered very well. He's now a strong advocate. He just joined the CCTG as a patient representative. He's in law school here in Toronto and wants to do health law and work towards changing some of the regulations around access to therapies. So I would argue that we need to see research as care. And there were reasons why it had to be so separate in the past, and those reasons still exist, but the way in which we view research as part of our care paradigm can still change. So we need to really invest in clinical trials and in clinical research as part of care. And the NHS has done this. They have earmarked a section or a percentage of their budget every year to clinical research because they recognize now that research is not separate, but it's part of care, it needs to be funded as part of care. And we need to get clinical trial infrastructure, not just at the highest academic centers, but also in the community centers. We should have a national REB, again, like they do in the UK. So a trial doesn't have to go through multiple REBs at all these different centers. It does not make sense. If it's ethical at one center, it should be ethical at all centers in our country. And I think that would significantly increase the speed and reduce the regulatory burden. We have to consider having incentives so that clinical trials will come to Canada, so that our patients can have access, not at the time of regulatory approval, and not even after that, but before, especially for high fatality cancers and for rare cancers. We need to consider decentralization to reduce barriers to participation so that patients can participate across the country. We need to allow clinical trial centers to form networks so they can be seen as one unit from a regulatory standpoint, so they can delegate some of these requirements. So decentralization will allow equal access and will reduce some of the geographic disparities and the socioeconomic disparities. Virtual care has been embraced, but virtual care for research has not. We need to probably work with Canada's rare disease strategy because now cancer is becoming a whole bunch of rare diseases. And we need to develop partnerships with industries to be able to fund novel drugs, but to be able to collect the data for those patients and those drugs real time so that we can make real world evidence about what their therapies are doing. And we have to be really forward thinking about our approach to molecular testing so that everyone can have access, not just for drugs that are already approved, but for drugs that might be available in clinical trials. We can't generate real world evidence if we aren't even testing patients. Patients have a lot of courage and they deserve to have the hope that we can bring through research, not just for people like Adam and Camille and Hayden, but for all of our patients. My experience with Adam led us, myself, Dr. Bell, my mentor, and one of my colleagues, Dr. Ilko, to form the Canadian Cholangiocarcinoma Collaborative, where we feel that hope grows. Basically, our vision is to create a partnership with patients, caregivers, oncologists, and researchers to grow hope by getting access to molecular testing, to research, to clinical trials. We have a number of different initiatives. My initiative is in one, which is the HOPE AIM, but we're also doing a T-cell trial so that patients in Canada can have access to the treatment that Melinda and my husband Adam were able to access through traveling out of the country. And this initiative is funded through the Canadian Cancer Society and CIHR. And so patients with biliary tract cancer, we hope will be able to get molecular testing. We'll have an opportunity to have their case presented at a multidisciplinary rounds. We'll be able to participate in having their data as part of an international registry. We'll have an opportunity to participate in the HOPE study that's run by our collaborator, who's a HOPE and COPE chair at McGill. I think, what can we all do? I think we can all remember to give our patients hope through the power of yet. When Adam and I went to see the oncologist for the first time, he had his clipboard and he wrote down stage 4 cholangiocarcinoma, not curable, treatable. And I said, I need your clipboard. And he gave me the clipboard, kind of looked confused. I said, I need your pen. And he gave me his pen. And where he said, we're not curable, I wrote ... not yet. We don't know what the future will hold. I don't think we should close the door for our patients. I think we need to try harder to figure out how to get the incredible advances that have happened in the lab to our patients for their benefit. So just picture myself with Camille and myself with Hayden. At 2 different times we went to Parliament to advocate for more funding for research to be integrated into care. Terry Fox believed that research builds hope. He was a young man, as we know. The night before he got his leg cut off for cancer, dreamed an audacious dream to run across the country with one leg that even his mother said you cannot do. And we think about Terry Fox running through the downtown Toronto core with everyone cheering, but we have to remember that when he dipped his foot into the Atlantic Ocean and ran all the way, almost clear through Quebec, there wasn't a single person with him. He ran alone. Nobody knew what he was doing, hadn't reached the press yet. No one really cared. Apparently he was driven off the road multiple times. When he was asked, how do you run, every day, face the idea that you're running across Canada? He said, I don't. I run 1 mile at a time. His brother Daryl would drive the van 1 mile, and he would run to the van. So most of my friends who know me, they make fun of me because they always say, come on, Rebecca, just run to the van. Just run to the van. You just have to run 1 mile at a time. No, thank you.
Well, it was incredibly inspirational and excellent. And I'm tempted to just sort of let it sit. We are at a time, but I recognize there are a lot of learners here, a lot of surgical oncology fellows and residents. I wonder if you could just comment on one thing. We often hear from various other clinicians, does this person realize what their prognosis is? Right? They don't seem to understand what their prognosis is, as if we have not told them their horrible prognosis. Do you have any words of advice for our residents and fellows who are in clinic with patients in this situation about how they frame that? How do they communicate with that patient who, by all metrics, there is no hope? What words should they use?
Yeah, I think it's a very good question. And I guess I have changed how I think about this now than in the past. I think you need to be honest, particularly if the patient is asking about what the actual data shows. But the data only shows population level data. It doesn't tell us what's going to happen for you. So I think you can't hide the facts. You have to be honest about the facts. But she just before Christmas, I had a 29-year-old with terrible Ewing's sarcoma that was progressing on chemo and had to, was either do surgery or nothing. And she sort of said to me, everyone says the chance of this coming back is so high. Should I just prepare for that? Should I just be ready for that? And I said, you could, or you could decide that you believe that it won't come back and live your life like that. It might come back. It might, but it might not. And how do you want to live? Do you want to live every day thinking it might? Or do you want to live every day thinking it might not? I think it's about the journey. Again, I don't think you can give false hope. I think you can give the information and let them decide.
Thank you again.
Thanks to everyone online. Rebecca will be here for a few minutes if anyone wants to come down and meet her or ask a question. Thanks for being here.
And actually, I spent it online from my previous chair. So what I'll do is I'll email it to you if you want to answer it. If you don't, that's okay.
From Jim.
Yeah, yeah. He was just kind of wondering about how to level the playing field with disparities of the low middle income countries. You know, it's hard to do nothing in Canada. So I'll flip the email to you.
I'll talk to you later. I know there are other people who want to talk to you, but we're meeting at some point to make it.
Here we go. Cardiac service. Stan.